Namaskar, dear viewers. Welcome to today's session of Critical Lines podcast. So today with us, we have a very esteemed faculty, Dr. SRINIVAS, SAMAVEDAM, very well known to all of you, prominent teacher and a prominent faculty for intensive care in our country. So sir is Chief of Critical Care at Ramdev Rao Hospital, Hyderabad. He is President of the Indian Society of Critical Care Medicine, and he was the scientific chairman for Critical Care Kochi 2025. He is the author of several publications, and he holds a diploma in medical law and ethics, amongst many other distinctions. So, with that brief introduction, I shall now start our podcast, and we will cover a wide array of topics in intensive care. I am sure you shall find it very useful, sir being so knowledgeable and updated in critical care. So, Dr. Samavedam, sir, the first question is about sepsis. Sepsis always being a burning topic and something which should be discussed in detail. And it's about temperature. Most of the patients are either febrile or have a normal temperature, but 10 to 20% are supposed to be hypothermic. First of all, in our ICUs, we really don't record hypothermia, though it's very clear that 10 to 20% are hypothermic. So why is that? Question number one. Question number two, what is the mechanism for hypothermia?
Tapesh, for having me on this podcast, and the young intensivist group has actually revolutionized the way critical care is taught and understood in this country, and I must congratulate you, Tapesh, for that achievement.
Thank you, sir.
While coming to the question, how often you will see hypothermia and why does it happen? The reason why hypothermia is a little underdiagnosed or underreported in our patients is the way we measure the temperature in our ICUs. Ambient temperatures in our ICUs are variable, and we don't actually have a uniform temperature control in our ICUs for various reasons. So there is a little bit of heterogeneity. When you talk about hypothermia or hypothermia, it is always about the core temperature. It's not about the surface temperature. And we usually do not measure the core temperature in our hemodynamically unstable patients. So the incidence of hypothermia may be actually a little higher. The hypothermia may be actually higher than what we are reporting. But hypothermia is a more common manifestation of endotoxemia and is more often associated with gram-positive infections. Because of the higher prevalence of gram-negative infections in our part of the world, maybe we don't see hypothermia as often as we see hyperthermia. So why does it happen? It happens because of the dysregulated immune response. It happens as a result of the endotoxemia. It also happens as a result of the dysregulated vasomotor response because of the glycocalyx denudation and dysfunction and the vasodilatation that accompanies sepsis. This is the common causes. Apart from that, one of the causes of hypothermia among patients with sepsis is adrenal insufficiency. It is both hyper and hypothermia can happen in patients with adrenal insufficiency, but when the real cortisol deficiency is actually prevalent in the patient, these patients are usually hypothermic. Of course, you will have the pituitary dysfunction also associated with sepsis, and therefore you will also have a thyroid dysfunction. You know that patients with sepsis can have a sick euthyroid syndrome. The sick euthyroid can have a subclinical hypothyroid phase, and that also contributes to hypothermia. And the repeated exposure of these patients for procedures, for sonography, for transport, also contributes to the degree of hypothermia in these patients.
Yeah, thank you, sir, for the answer. Then moving on to the next question is about Guillain-Barré syndrome. So this is a syndrome in which there is autonomic fluctuation in blood pressure and heart rate, which is very common. And this can range from bradycardia to tachycardia and from hypertension to hypertension. That is, wide swings can occur in the same patient, making it a very challenging situation and, of course, life-threatening. So what is the recommended approach to manage these autonomic fluctuations in GBS?
So Autonomic instability is quite often encountered in IDP or Guillain-Barré syndrome. More often, it is an epiphenomenon of the disease and is not usually hemodynamically significant. But sometimes it becomes hemodynamically significant. So your hypotensions that happen should probably be managed with phenylephrine or methyltramine. The bradycardia, we know, can be managed with pacing, external or transvenous pacing if it persistent. The clue is not to use centrally acting drugs in controlling the tachycardia for these patients or the hypertension in these patients because they usually will fail because that's where the dysregulation has happened. So the peripherally acting drugs like an ivabradine or maybe even a beta blocker may be used if the tachycardia is a problem. But the real solution for managing these patients is to use the therapeutic armamentarium we have for GB syndrome, that is IVIG and plasma exchange. Between the two, if the hemodynamic instability is very significant, the variability in the heart rate and the blood pressure is very significant, IVIG may be preferable to plasma exchange. But if it is the hypertension and bradycardia syndromes that are more common or the more predominant manifestations, then either plasma exchange or IVIG may be the solution to this.
Thank you, sir. Moving on in the next question about brain death. We typically rely on the apnea test to diagnose brain death, amongst other things. However, when the apnea test cannot be performed due to desaturation, arrhythmia, or hypotension, how do we confirm brain death in such situations?
So, initial desaturation may be overcome by jet oxygenation or jet ventilation, and then the saturations comes up. You can do the brain death testing. If that also does not settle the oxygenation issue, the conventional apnea test cannot be done because it is one of the exclusion criteria for performing. So in such situations, ancillary tests may have to be resorted to, like cerebral angiography, transcranial Doppler, near-infrared spectroscopy, and bedside electroencephalography. But legally, these are only ancillary tests. You should make an attempt to repeat the apnea test maybe 6 to 12 hours after the initial desaturation. You need to go back and see the causes for such desaturation. Is it a fluid overload? Or is it a mucus plugging of the bronchial tree, or is it a fresh infective process? Try to sort out those issues and come back and repeat the apnea test because the apnea test still remains the gold standard for diagnosis of brain death.
Great, sir. Thank you. Now, moving on to a very frequent problem and a basic problem, hypokalemia. So sometimes we have these patients with refractory hypokalemia and the etiology is not immediately clear. How should we investigate these patients with unexplained or refractory hypokalemia?
So one of the reasons why we fail to correct hypokalemia in our ICUs is one, we don't measure the transtubular potassium gradient, and two, we don't give much importance to hypomagnesemia and hypophosphatemia. Now, the transtubular potassium gradient is very important because patients who are on certain drugs, like azole-containing drugs, like acyclovir, like amphotericin B, these are all patients who will have leaky tubules. So, if you document that the tubular excretion of potassium is high, no amount of parenteral correction will correct your potassium unless you use a drug like spironolactone, which is or triamterene amiloride, which can conserve the urinary potassium. So we always have, when you have a patient whom you have used 100 or 120 milliequivalents of potassium, and you don't see even a marginal improvement in the serum potassium level, you have to look at the transtubular potassium gradient to know whether this patient is leaking potassium in his renal tubules. Then, of course, you need to, most commonly, we look at magnesium, but we don't look at phosphate as a cause of hypokalemia because that also has the ATPase pump in the tubules also depends on phosphate. So a hypophosphatemia can also result in hypokalemia. So these aspects have to be uh, looked at. Certain drugs which can actually trigger insulin production will produce hypokalemia, notoriously piperacillin tazobactam. It can actually trigger a hypokalemic problem in these patients. So you need to look at all these all these uh, events if you are dealing with a patient who has a refractory hypokalemia.
Thank you, sir. The next question is about angiotensin 2. So it's a new kid in the block as far as vasopressors are concerned. Of course, we don't have it in our country to the best of our knowledge, and it's still very expensive. However, I think it'll be coming soon. So, as far as its use is concerned in septic shock as a vasopressor, would you like to discuss its mechanism, indications, and clinical pharmacology, sir?
So angiotensin 2 is a good drug. We have currently two mechanisms of vasopressor activity that we manage with. One is the sympathomimetic receptors, that is norepinephrine, epinephrine, and you have the aquaporin receptors where we use vasopressin, terlipressin for patients with septic shock. Now, a third receptor, that is the renin and angiotensin receptor, is the one which is being hypothesized for these patients. In sepsis, because of the capillary leak, there are a subset of patients who have low renin, high aldosterone hypotension, and some people who have a high renin, low aldosterone, and low and hypotension. So the assessment of the renin activity based on the plasma renin activity, those who have a variation in the renin values are candidates for angiotensin 2. Is it going to be a third drug? I am not sure. But I'm very convinced that it is definitely going to be an alternative to vasopressin. We are going to look at situations in future where you have started norepinephrine, patient is hemodynamically unstable, you want to add a second vasopressor, then you look at the renin activity, and then based on the renin activity, you decide whether this is the angiotensin responsive hypotension or an angiotensin unresponsive hypotension. And based on that, you will decide whether to give angiotensin 2 to the patient or you will give vasopressin to the patient.
Thank you, sir. Then moving on to sepsis again. We're going back to sepsis. So we have DIC in sepsis, which is rampant, as you know, sir. So earlier we had only PT and APDT, but these now we know do not really reflect the coagulation status and generally are prolonged in sepsis, despite the patient being hypercoagulable or hypocoagulable, it does not reflect properly. But now with TEG and Rotem, the viscoelastic test, we can accurately predict where the patient is on the coagulation path or the profile as far as coagulation is concerned. So, how do these newer tests like TEG and Rotem improve the diagnosis and management of DIC in sepsis?
It's a good question, Pravesh. Now, when you look at DIC, we know that there are at least 3 or 4 different phenotypes of DIC. One is a clotting type of DIC, which is very common in sepsis and malignancy. Two is the bleeding type of DIC, which is very common in trauma and obstetric hemorrhage. And then you have the simmering DIC, where there is no obvious bleeding tendency, but you have an abnormal prothrombin time, INR, platelet count, and fibrinogen if you test the patient with an underlying disease which causes DIC. And the fourth type of DIC, where there is a cause, there is a bleeding tendency, but when you look at these numbers, the numbers are not very bad. Now, this fourth type of patient is the one who needs a viscoelastic testing, where you actually identify whether there is a problem at clot initiation, whether there is a problem with the maximum amplitude, the clot stabilization, or clot lysis. So if there is a hyperfibrinolytic mechanism, you use a different kinds of drugs. If there is a platelet plug formation, you use maybe FFPs and platelet transfusion. If you have a clot stabilizing problem, you use a fibrinogen containing like a cryoprecipitate. So while it is easy to throw all the blood products you know at a patient, it probably adds to the burden and contributes to the transfusion associated lung injury in these patients. So, to judiciously use scarce resources like FFP, cryoprecipitate, and fibrinogen concentrates, the use of Rotem or viscoelastic point of care testing will guide us more appropriately where exactly in the clotting cascade the clotting system is failing.
Yeah, thank you, sir. Definitely, I think TECG and Rotem is the way forward with DIC in sepsis, and a lot of papers have also come out. And the final question, sir, moving on to the world of research. So, stem cell therapy has been tried in various situations in intensive care. So, would you like to just tell us about the status of stem cell therapy in intensive care? What is actually going on? Just something you can tell us.
Stem cell therapy is always very exciting, hypothetically very appealing method, unfortunately not matched by clinical results. But stem cell stem cell therapy is going to be very effective or is making some advances is in patients with fibroproliferative stage of ARDS. We don't have much therapeutic we have we don't have much therapeutic options left for the proliferative stage of ARDS, and we don't have much therapeutic choices for the fibroproliferative stage of ARDS. So stem cells are being tried in that context. The second area where I think will make a difference is in the patient with traumatic spinal cord injury who are paraplegic or quadriplegic. In such situations, there are some studies which are being done where stem cells are being shown to improve the motor recovery of these patients. Sensory recovery has not yet been documented, but motor recovery is being shown. So these are some areas where stem cell therapy is being tried.
Great, sir. So that was the final question, and we have a huge audience, sir. Thank you so much, attesting to your great, capacity and respect for you as a teacher and as an intensivist in the country. Thank you very much, SAMAVEDAM, sir, and I thank the audience for joining in for their patient hearing. Thank you, everybody. Good night.
All the best for your program, Kapesh.
Thank you, sir.
God
All the
bless you.
best to you, sir. All the best to you.